This is Dr. Joanne Manson, Chief of the Division of Preventive Medicine at Brigham and Women's Hospital, Professor of Medicine at Harvard Medical School, and lead author of the article in JAMA on the Women's Health Initiative, hormone therapy trials, and all-cause and cause-specific mortality over 18 years of follow-up. We examined all-cause mortality rates and rates of death from specific causes such as cardiovascular disease, cancer, and other major health conditions in the two parallel hormone therapy trials in the Women's Health Initiative. In the WHI, there were a total of more than 27,000 women who participated in the two hormone therapy trials, and they had a mean age of 63. We followed them during the intervention phase, which lasted 5 to 7 years on average, and also up to 18 years of cumulative follow-up for these analyses. Menopausal hormone therapy has a very complex pattern of benefits and risks. It's been linked to certain benefits, such as reducing hot flashes and menopausal symptoms, as well as reducing rates of bone fractures. However, it's also been linked to risks, such as increased risk of developing blood clots in the legs and lungs, stroke, and with estrogen plus progestin, an increased risk of breast cancer. In fact, the two hormone therapy trials were stopped early due to risks. So looking at all-cause mortality is critically important to have a summary measure of the net effect of hormone therapy on serious and life-threatening health conditions. And that was our goal in this study, to look at all-cause and cause-specific mortality during the intervention phase, as well as 10 to 12 years post-stopping hormone therapy, for a total of about 18 years of cumulative follow-up. In the two parallel hormone therapy trials of the Women's Health Initiative, there were 27,000 women who were randomized, and the trials tested the two most common formulations of estrogen plus progestin and estrogen alone that were used at the time the trials started. Over the 18 years of follow-up in our analyses, there were more than 7,000 deaths from all causes. And the women at the beginning of the study were ages 50 to 79 with a mean age of 63. And we followed them for all-cause and cause-specific mortality, including deaths from cardiovascular disease, cancer, and other major causes of death. Overall, during the intervention phase and over 18 years of cumulative follow-up, we found that hormone therapy, whether estrogen plus progestin or estrogen alone, did not increase or decrease the risk of all-cause mortality or cause-specific mortality. So deaths from all causes and deaths from cardiovascular disease, cancer, and other major causes were very similar between the hormone therapy groups and the placebo groups in the trial. So for example, among the women who were randomized to hormone therapy in the two studies pooled, about 27.1% of the women died from all causes, and in the placebo group, 27.6% of the women died from all causes over the 18 years. So the hazard ratio was 0.99. It was almost exactly the same in the hormone therapy groups and the placebo groups. Similarly, for cause-specific deaths, the rates were very similar between the hormone therapy and the placebo groups for cardiovascular mortality, cancer mortality, and deaths from other major causes. A key limitation of our study is that the Women's Health Initiative hormone therapy trials tested just a single formulation of estrogen and of estrogen plus progestin, the most common formulation at the time the trials were started. However, we are not certain that these results can be extrapolated to other formulations and routes of delivery of hormone therapy, such as transdermal preparations or lower doses. And many of those formulations are more commonly used in current clinical practice. I think the takeaway message of our study is that menopausal hormone therapy, whether estrogen plus progesterone or estrogen alone, is not associated with an increased or decreased risk of all-cause mortality or cause-specific mortality from major causes such as cardiovascular disease, cancer, or other major illnesses. And these findings may be helpful to clinicians in clinical decision-making and also helpful to patients to understand that there was no net effect on all-cause mortality, which would suggest that current guidelines that it's very reasonable to treat women who have moderate to severe hot flashes, night sweats, and may derive quality of benefits from hormone therapy, at least in early menopause, does seem appropriate. But treatment for prevention of cardiovascular disease or other chronic diseases would not be advisable in view of no evidence for any benefit in terms of all-cause mortality.